All right, so good evening and welcome to this International Center for Moral Injury webinar titled Silent Disaster, How Moral Injury Caused PPE and Distancing Changed England's Care Landscape, which will be presented by Dr. Andrea Lambell. My name is Brian Powers. I'm the Executive Director of the International Center for Moral Injury, or as we call it frequently, the ICMI. Let me just note that as with all of our webinars on moral injury, certain aspects of the conversation may evoke quite intense and personal feelings. So please exercise self-care and stepping away if you need to, and know there is help available if you feel overwhelmed. Jane is posting the link to one of the resources we frequently signpost, lifeline-international.com, and I would certainly invite you to utilize them if you feel you need. So without further ado, let me turn it over to Andrea for the presentation tonight. Andrea.
Thank you, Brian. Just to reiterate what Brian said before I start, I just want to highlight the fact that we all lived through the pandemic and we continue to live through its consequences. This presentation has content which might evoke some difficult memories and feelings, so please pay attention to your own well-being, and I won't be offended if you drop off the call. In tonight's presentation, I'm taking a biocultural approach, which is the explicit recognition of the dynamic interactions between humans as biological beings and the social, cultural, and physical environments that they inhabit. I aim firstly to explain how moral injury has been a consequence of the way the COVID pandemic was experienced in England in the context of health and social care. I will then go on to explore the theory that there is an ongoing disaster caused by that moral injury, manifested through the destabilisation of England's health and care infrastructure, through the profound effects of moral injury on health and care professionals and unpaid family carers. This makes the country vulnerable to future challenges, lowering the levels of resilience which prevent an emergency from becoming a disaster. Next slide, please, Jane. This presentation has 4 stages. First, I'll describe the complexity of the care dynamics and lived experience reported to me by my participants. Then I'll explain the distress of being unable to understand and be understood due to the presence of personal protective equipment and distancing. And I'll describe the body-mind mechanisms at play. I'll go on to examine how unavoidable distress was exacerbated through a potentially morally injurious culture created by a series of actions and omissions of people in power. I conclude with an examination of the consequences of inflicting moral injury on people with professional and personal caring responsibilities, and how this compromises the country's resilience to future emergencies. Next slide, please, Jane. I'll begin with a quick explanation for anyone who's unfamiliar with the United Kingdom's healthcare system. The NHS is the National Health Service, funded entirely by taxation and free at the point of contact. Social services, on the other hand, are provided through local government, and in England they are often means tested. In other nations of the UK, that's Wales, Northern Ireland, and particularly Scotland, we have different forms of devolved power, so circumstances can be quite different. All the participants in my research were situated in England. On the 25th of March 2020, Boris Johnson's Conservative government ordered the United Kingdom's population to stay home, protect the NHS and save lives as a strategy to lower the spread of the COVID-19 pandemic. Then on the 2nd of April, Public Health England advised health and social care workers that surgical masks and aprons should be used within 2 meters of a suspected or confirmed COVID-19 patient, with more closely fitting FFP3 masks and full arm gowns reserved for high risk procedures. Masks became mandatory in hospitals on the 15th of June and in shops and public transport on the 24th of July. The rules on masks and staying apart continued to fluctuate in different settings and populations over time until the last restrictions were withdrawn from health and care settings in the spring of 2022. My PhD set out to investigate how health and social care communication during the pandemic was affected by 2 factors: personal protective equipment, which became ubiquitously known as PPE, and the forced avoidance of touch and proximity, commonly referred to as social distancing. PPE included a plethora of artefacts which covered the face and body, masking the non-verbal cues which are important for communication and human connection. Distancing took two forms: the prevention of touch and proximity when meeting in person, and the use of remote means of communication to replace in-person interaction. I conducted an online survey between August and October 2020. In England, this was a window of time which began with the maximum amount of freedom after the initial imposition of pandemic measures, and it ended with the announcement of the second national lockdown. I disseminated the survey through a range of patient representative groups and professional networks. There were 464 respondents, more than 80% of whom had given and/or received care in the presence of PPE and distancing. I identified 33 people with a range of care experiences and interviewed them between August and December 2020. Then I re-interviewed 9 of them between March and May 2022. Next slide, please, Jane. I conducted a case-based thematic analysis of the interviews and survey responses. One of the first things that struck me was how I could not categorise participants as either caregivers or care receivers. Many participants who self-identified as health and care professionals had episodes of acute medical need themselves, while conversely some with complex health and social care needs were themselves important sources of support to peers and professionals. 23 of the 33 participants both gave and received care. 8 were exclusively caregivers and only 2 participants had no experience of caregiving. This slide describes the roles and experiences of just a few of the diverse participants who were all given pseudonyms. They were all simply people negotiating the complexity of their lives during COVID. Next slide, please, Jane. A common feature of people's stories was the experience of giving care to family members in an unpaid capacity. NHS England's definition of this type of care is a person who looks after a family member, partner or friend who needs help because of their illness, frailty, disability, mental health problem or an addiction and cannot cope without their support, and the care they give is unpaid. 2 participants worked for a charity which supported the unpaid family carers of disabled children and people with dementia. 5 participants were family carers who extended their substantial personal caring roles for husbands and a sibling into a wider voluntary peer support role. The wife or daughter of 3 participants gave birth, but the distancing rules meant they were unable to support them. 2 health professionals worked full-time while also being substantially responsible for the care of close family members with complex needs. Maggie, a therapist in NHS Children's Services, had the role of family carer thrust suddenly upon her. Her father was one of the first COVID patients in his hospital's intensive care unit in the second week of March 2020. Now, Maggie's mother had dementia, so Maggie suddenly became a lockdown live-in carer for her mother while continuing to work remotely from a parent's spare bedroom. Next slide, please, Jane. The essential care work done by unpaid family carers in England and Wales has a monetary value equivalent to the entire NHS budget, saving the public purse £18.6 million every hour. In return, eligible applicants can claim a state benefit of £81.90 a week. Claimants must give at least 35 hours a week of their time to their caring role to qualify and must not be in education for 21 hours a week or more. If they do manage to hold down a paid job as well, this employment must not pay more than £151 a week. And if their income breaks this threshold, even by £1, the claimant becomes ineligible for the whole amount and has to pay it back. Right, I now turn to what I learned from my research participants. Next slide, please. In a breakout of a novel disease, until effective medicines are identified and made widely available, all we have are non-pharmacological infection control measures. That is, staying apart, covering up, disinfecting everything. So, PPE and distancing were unavoidable. We could not avoid the claustrophobic sensory sensations caused by the masks, the gloves, the visors and gowns, or the denial of reassuring stimuli such as touch and non-verbal visual clues. A very common complaint was the sensory disorientation caused when the masked breath missed the internal surfaces of visors and spectacles. We couldn't avoid the fact either that the measures existed because of a threat to life. According to the Office for National Statistics, between the 9th of March and the 20th of July 2020, COVID was involved in 30% of the deaths of health and social care workers aged 20 to 65 in England and Wales, compared to 16.6% of the general population of the same age. This landscape created a double bind. Anxiety was also triggered by the absence of PPE or the presence of touch and proximity. Habituation describes decreased responsiveness to a stimulus with repeated presentation. It's important for cognitive tasks such as interpersonal communication because it filters out irrelevant information, such as the feeling of one's clothes. The opposite of habituation is sensitization, the increased responsiveness to a stimulus with repeated presentation, especially if the stimulus is annoying or reverse. So for some people, the body-mind experience of attempting to communicate just got worse as time went on. Next slide, please, Jane. Communication is central to ethical caregiving, not just for making meaningful connections, but also for the basic function of gaining informed consent. Many participants described what I call communication distress, the suffering caused by being unable to effectively communicate. I consider that to be a form of moral distress as conceptualized by Andrew Jameson in 1984. I'll give you a moment to read these comments from participants, just a small selection of the distress expressed by survey respondents and interview participants alike. The distress caused by unavoidable stimuli was exacerbated by factors which could have been avoided or mitigated against through appropriate planning, leadership and communication. Distress was amplified by the substandard quality and lack of availability of PPE artifacts, of the equipment and the infrastructure required to facilitate effective remote communication, and the quality and nature of the explicit and implicit communication emanating from the authorities responsible for the infection control measures. Next slide, please, Jane. Louise was an advanced nurse practitioner in urgent care. Her story illustrates how the intrinsic difficulties of communicating in the presence of PPE and distancing were made worse through extrinsic factors: poor quality resources, untruths about their suitability had a disturbing effect on the care she was able to give to an elderly couple in crisis, one of whom was an unpaid family carer. Here is my interpretation of an incident she told me about, a vignette which I composed from extracts from her verbatim interview transcript. With a medical bag in her hand, Louise heads through the darkness for the house of Mr. Granger, who has respiratory distress, confirmed COVID. His wife answers the door. Louise steps into the hallway. The stifling air of the overheated house condenses both on her cold visor and the spectacles she wears, double layer steam. She goes back to the door, acclimatizes, demists herself before going back in. It's clear that Mr. Granger needs to go to hospital. It's a struggle to be heard through the mask and the visor, but Louise perseveres, projecting her voice as loudly as she can, just short of full-on shouting, enunciating her words as clearly as possible. Though it's a skill she's developed over these long months of PPE wearing, her diaphragm still aches from the effort, especially when using her usual communication tactics, getting down to the same level as the bedbound man, twisting her body to make eye contact, then turning to look up to Mrs. Granger hovering above. The flimsy plastic apron rustles and rips. Her glasses and visor steam up again, like the silvering on the back of a mirror as her breath is funneled upwards by the surgical mask. Not much chance of Mrs. Granger seeing the smile in my eyes through this, Louise thinks. Indeed, all Mrs. Granger can see is her own distorted reflection on the visor's plastic surface. Louise's effort is emotional and psychological as well as physical. As the couple are not convinced that hospital is the safest place for Mr. Granger, they do not want to be parted. But this is an emergency and they allow Louise to call an ambulance. And then the next phase begins, the wait. She's told to expect it in an hour. And all the while, Louise is calculating risk. Mr. Granger has a desperate need for oxygen and the cylinder only holds 40 minutes worth. She realises she must ration the oxygen she has. She puts the oxygen mask on his face, takes it off, repeats the process. The guidelines say her surgical mask is enough to protect her, but research has proved otherwise. But still, community clinicians like her don't have access to the fitted face masks that her hospital-based colleagues do. So a reflex action makes Louise turn her face away from the scared eyes of the coughing man. There's another risk assessment going on, which means she can't do what her instinct tells her to do. In all probability, this man is dying in front of her eyes. She would have sounded his chest, taken his pulse, held his hand, and soothed his brow. Actions rather than just words, a comfort to both her patient and his wife. But a voice in her head is saying, I haven't got good enough PPE. It's no good me listening to this person's chest. That would mean putting me at extra risk. There's no benefit. I'm not going to do anything different, and I'll know if I need to do CPR. Louise hovers in the hallway whenever she feels able to step away, just to limit her exposure, for the sake of her next patient, for the sake of her own family. When the ambulance comes, she hands over to the paramedics, who take Mr. Granger away, leaving his wife behind. Mrs. Granger is inconsolable. Louise tries her best and fails to express empathy. No amount of exaggerated body language and muffled words of sympathy can do the work of the hug she longs to give. But if she could offer it, would it be welcome? Mrs. Granger's just witnessed Louise treating her husband in the most detached, functional way. They say goodbye at the front step, but as Louise peels off her layers and wrangles them into the wind-blown yellow waste bag, she can hear Mrs. Granger's sobs through the closed door. The rest of the shift is a blur, and Louise heads home in the weak morning light. Now comes another doffing routine, a parody of her professional practice. This time it's for the protection of her own family, and quite a few of her colleagues have confessed that they're doing the same when they get home. Louise, like so many other nurses, has reinstated her homecoming ritual from the spring of 2020. Back then, it was a response to knowing too little about the virus. Now, maybe they know too much. This time, they know they haven't got the right PPE. She leaves her shoes outside, strips naked in the hallway, throws her clothes in the washing machine, and runs up to the shower. Louise's story illustrates how the physical neurosensory stimulation of the PPE and the emotional response arising from its distressing context are intertwined in a biocultural way. Next slide, please, Jay. General adaptation syndrome, described by Hans Selye in 1936, is the neuroendocrine response to unresolved emotional stress, which affects the body's immune functions on a cellular level. It has three phases: alarm, adaptation, and exhaustion. In the alarm stage, powerful feelings caused by a stressor trigger a cascade of hormones and neurotransmitters to evoke a necessary and normal fight or flight response. Adaptation normally occurs when the stress passes and the body's homeostatic regulation returns the neurochemicals to their pre-stress levels. But if adaptation fails, the hormones continue to be produced in response to an alarm for which they are no longer appropriate, and the person enters the exhaustion phase, where unbalanced levels of hormones affect the body-mind on a cellular level, inducing physical and emotional pathologies, including forgetfulness, emotional lability, such as tearfulness or anger, and physical fatigue. This syndrome, embedded in the physiological, is profoundly affected by socio-cultural factors which moderate the level of stress. This two-way link between neurobiology and the socio-cultural sphere has been established and developed by trauma clinicians such as Bessel van der Kolk, who in 2014 identified the socio-cultural circumstances which can provoke or mitigate against the development of general adaptation syndrome, or GAS for short. He identifies the centrality of relationships and community to well-being, the transformative power of language and communication. And these factors create specific physical and cultural environments which influence the mechanisms of GAS. When communication fails and trust is lost, the circumstances are set for the neuroendocrine response of GAS to unfold. We've seen how communication could fail and how lack of trust exacerbated this failure. Louise's story gives us insight into how her distress was heightened by the lack of trust in the effectiveness of PPE and in the authorities who wrongly insisted that it was inappropriate. The loss of trust is a key factor in the creation of a state of normlessness, which had had a profound effect on professional healthcare workers and family carers alike. Next slide, please, Jane. Anomie, according to Durkheim, is a state of normlessness, disorder, or confusion in a society where the standard norms and values are weak and unclear. This lack of social or ethical standards can lead to disconnection, deviance, and social instability. Here's one example of normlessness. The UK government's Eat Out to Help Out scheme paid hospitality establishments to give 50% discount on food or soft drinks consumed inside restaurants, cafes, and pubs on most weeknights in August 2020. Some interview participants, like Beth here, expressed their distress at the moral dissonance between a suite of policies which encourage proximity and socialisation between strangers in hospitality venues, while forcing separation from loved ones in health and care settings. Beth here speaks as a patient, but she's also a nurse. Her colleagues were expected to enforce this separation and thus help to perpetrate a potentially morally injurious experience, or PMIE for short. People who experience PMIEs can be a perpetrator, a victim, or both. Next slide, please, Jane. There are two well-known definitions of a potentially morally injurious experience. Brett Litz and his colleagues in 2009 described it as perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. In 2014, Jonathan Shea called it a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation. In the prescriptive cognition model of moral injury, posited by Farnsworth, Drescher, Evans, and Walser in 2017, the moral injury is not the damage associated with the triggering event, or even from the moral pain which ensues. According to Farnsworth and colleagues, moral injury occurs only when the potentially morally injurious experience is accompanied by two other factors. Firstly, the sufferer adopts inaccurate moral emotions which condemn themselves and/or others. And then they attempt costly or unworkable attempts to manage, control, or cope with the experience of moral pain. The moral injury is the manifestation of maladaptive behaviours such as self-handicapping, substance use, behavioural avoidance, and social isolation, which may affect the number and quality of an individual's relationships and their ability to find meaning in activities of community living, for example, work, school, or religious traditions. And finding meaning from his religious activities was indeed problematic for church deacon and GP practice manager Dave. Dave described in detail his changed relationship with his faith, his work, his family, and the world in general in the aftermath of the many repeated PMIEs he had experienced over the previous year. Next slide, please, Jane. In 2019, William Nash pointed out that the prescriptive cognition model can only apply to people with the mental capacity to accurately appraise the challenges they face. The stress injury model of moral injury offers an alternative explanation which is more compatible with the biocultural experience. The physical and emotional pathologies of general adaptation syndrome described earlier, including forgetfulness, emotional lability, the tearfulness and anger, and the physical fatigue, were reported by many participants, regardless of whether they explicitly described being morally injured by their experiences. Here, Veronica describes her bewilderment at her tearfulness. General adaptation syndrome is central to the stress injury model of moral injury. According to this model, the cascade of hormones and neurotransmitters provoked by a PMIE inflict what Nash describes as a literal wound to the mind, brain, body, and spirit. If the body's homeostatic rebalancing response is functioning correctly, the strain is reversible and within the bounds of normal life stresses. However, when distress or alterations in functioning persist, despite adequate rest, Nash says irreversible but possibly repairable moral injury has occurred. One can see how the body-mind response to a PMIE can traverse through the three phases of GAS to the exhaustion stage, especially if exposure is extreme and or if repeated exposure results in sensitization rather than habituation. In 2011, Shea stated that it's enough only to experience a potentially morally injurious event for a moral injury to be imprinted upon the body-mind. In his assertion, he reiterates his definition of PMIE, a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation, and continues, when all three are present, moral injury is present, and the body codes it in much the same way as it codes physical attack. The exquisitely biocultural experiences of being with PPE and forced avoidance of touch, and the prolonged period under which the objects and behaviours were salient, makes the stress injury model a particularly relevant way to interpret the participants' moral injuries. Next slide, please, Jane. Though acute moral distress decreases after the situation passes, some painful feelings can linger. In 2009, Epstein and Hamrick called this moral residue. Ooh, can you slip back one? Thanks. Moral residue, which serves as a new, more sensitized baseline for the next episode of moral distress. In a theory which they called the crescendo effect, they described how over time, as repeated crescendos of moral distress are experienced, the baseline of the moral residue itself increases to its own crescendo, making the sufferer sensitized to any future episode. Now, Dave's comments here about his colleagues from 2020 and 2022 are an illustration of the crescendo effect. Now I've established the mechanisms of moral injury, I'll explore in more detail the morally injurious events described by the participants. The experiences they described revealed that communication about PPE and distancing is as influential as artifacts and behaviours themselves. Communication in all these forms provoked strong negative emotional responses, not least the behaviours of those who made the rules. We'll have that next slide, please, Jane. The Cummings effect. According to Fancourt, Steptoe and Wright of University College London, it's a loss of trust demonstrating how dangerous leader exceptionalism can be for collective citizenship and social unity. The Cummings effect is named after Prime Minister Boris Johnson's special advisor, Dominic Cummings. On the 27th of March 2020, Cummings and his wife developed COVID symptoms. In contravention of a 14-day isolation period for anyone with COVID symptoms and of the national stay-at-home lockdown instruction, he drove his family more than 250 miles from London to his parents' home in Durham, near our university. When the incident became public, Johnson told a press conference on the 24th of May that Cummings had no alternative but to make the journey to secure childcare. Johnson said, Cummings followed the instincts of every father and every parent, and I do not mark him down for that. Looking at the very severe childcare difficulties that presented themselves to Dominic Cummings and his family, I think that what they did was totally understandable. Johnson's description of this transgression as an example of responsible and appropriate care behaviour suddenly reframed law-abiding family carers as the perpetrators of a betrayal. He was effectively telling them that they had unnecessarily abandoned their loved ones by adhering to the ban on visiting other households. That press conference was potentially morally injurious for family carers, as indicated by Paula, the carer support worker quoted here. Cummings' disclosures about his behaviour and Johnson's supportive response to it correlated with the sudden and steep decline in markers of public trust and confidence in the government, as measured by University College London's COVID-19 social study. It's an example of how moral injury has consequences for social cohesion. Next slide, please. As I was analysing the data looking for instances of in-person distancing and remote communication, a third form of distancing emerged, which I call institutional distancing. Many participants reported the withdrawal of essential health and or social care services. This withdrawal happened in two phases. There was the effect of the Conservative government's austerity programme, a pre-existing longer-term attrition of resources combined with policies which situated care responsibilities with the individual rather than the state. Then there was the pandemic-related withdrawal, the consequence of a reactive shift in allocation of resources in direct response to the crisis. Both circumstances led to an increase in the unacknowledged burden of unpaid family care. This disconnection between people and care structures qualifies as social arrangements that put individuals and population in harm's way. Now, that is Paul Farmer's definition of structural violence. Next slide, please. Audrey here is describing the moment when she realised that her husband's Parkinson's medical and nursing support infrastructure had been dismantled. Audrey's husband died 2 years before the pandemic. Since the introduction of austerity policies in the early 2010s, the goodwill of unpaid family carers has been utilised as a cost-saving alternative to investing in social services. Higgins and O'Leary coined the term responsibilised commoditisation to describe how family members' sense of responsibility is monetised by the state. Family members are left with little option but to assume responsibility regardless of their personal resources or abilities. The allocation of a carer identity, whether willingly accepted or imposed without consent, can be a source of moral dilemma and moral distress. Often the role occurs through accident of kinship and or proximity. To refuse or resist the role is a morally complex process which firstly requires one to identify one's actual or potential caring role, and then to navigate the emotional labour and practical landscape of asserting one's own needs against those of a vulnerable person for whom it is assumed one holds unconditional positive regard. This assumption of an untroubled and emotionally beneficial relationship is reinforced by the ubiquitous term loved ones in health and care interactions concerning relatives who give and receive practical care. Next slide, please. According to Miranda Fricker, epistemic injustice is a wrong done to someone specifically in their capacity as a knower. This translates into moral injustice and moral distress. Hermeneutical epistemic injustice. occurs when someone's experiences are not well understood by themselves or by others. It takes an average of 2 years for a person who has taken responsibility for caring duties to see themselves as a carer. GP practice manager Dave said that his surgery's efforts to connect unpaid family carers to services struggled to transcend the pre-existing reluctance of carers to self-identify with that role, considering it disrespectful to their spousal identity. Next slide, please. Testimonial epistemic injustice occurs when prejudice causes a hearer to give a deflated level of credibility to a speaker's word. Authorities disengaged from dialogue with unpaid carers and the people they cared for, to the point where their existence went unregistered through lack of accurate records. There was a failure to acknowledge their needs and/or the value of the work that they do. In public discourse, the term carer was used to describe the people who were in the front line of the pandemic response. It was usually accompanied by images of paid health and social care staff, but most frequently nurses and doctors. This amounted to a testimonial form of epistemic injustice upon unpaid carers whose labour was considered as merely a fulfilment of familial duty rather than a contribution to the nation's care effort. Next slide, please. The suspension of essential social daycare services resulted in crises for the families of people with complex needs, as described by carer support workers Liz and Paula. Day services and respite were shut down and no alternative was offered. Paula said families were struggling to cope alone, particularly because the restrictions on movement and/or the desire to avoid infection risks removed access to simple activities outside the home which could give structure to the day, such as taking a walk or going to a cafe. The ban on mixing of households prevented other friends and family coming in to offer additional unpaid support to compensate for this absence of official services. Liz described how some domiciliary care clients and their families felt vulnerable to COVID because they were aware of the multiple contacts the care workers were having, both through their job and their social lives. They also reported that domiciliary care workers were using the same PPE for multiple contacts. The client or their family had to evaluate the threat posed to them by this exposure and balance it against the necessity of the support those workers provided. They then had to decide whether to attempt to negotiate with the care workers about their PPE and distancing behaviours. The families Liz supported had no decisive government guidance in these difficult negotiations, another example of responsibilised commoditisation. When I spoke to Paula again in 2022, the disconnect between unpaid family carers and any form of support infrastructure had a feeling of permanence. She said the logjam in the assessment of needs in existing and new cases and the provision of appropriate care to meet those needs was still unresolved. This left the financial burden and/or the practical caring tasks to be met by unpaid family carers. Many services continued to be suspended or reduced. Some people lost their permanent placements, and some services no longer existed. Next slide, please. The consequences of being a responsibilised relative were described by Laura, who was sole carer for her husband who had Parkinson's. The system assumed Laura was coping unless she explicitly told someone otherwise, and Laura's health was only addressed when crisis point was reached, and her husband Henry was admitted to a neuropsychiatric unit. This extreme form of institutional distancing and structural violence became worse during the pandemic, when the imperative was to minimise non-COVID cases in hospitals. Here, Laura is describing the experience of a fellow carer who she was supporting by telephone. And she was the wife of a gentleman whose Parkinson's had progressed to include a form of dementia which affected his personality. Next slide, please. Earlier, Louisa's story included an impossible choice between family or profession. She compromised the quality of her professional care when she avoided being close to a sick patient to minimise the chance of going on to infect her family. But then her homecoming ritual, the stripping off and the laundering the clothes and the showering, was a mainly futile attempt to reduce the risk of infecting her family. Now here, care home training manager Alex had a moral dilemma which was even more complex. Her need to foreground her professional carer identity meant she had to stop visiting her grandmother, for whom she performed essential personal care. Yet she used self-critical language when she spoke of the double bind in which she and her colleagues were caught. She said it was selfish to have fears for the safety of one's own family, as well as the people in one's professional care. Next slide, please. The ability to control unwanted memories is critical for maintaining cognitive function and mental health. And active forgetting adapts memory to be aligned with cognitive and emotional goals. Anthropologically, Paul Connaughton describes multiple forms of forgetting, some of which are deliberate attempts to protect people, sometimes from pain, sometimes from retribution. But this is problematic when those who suffer epistemic injustice are also those who carry the main burden of memory. As the nation emerged from the acute phase of the pandemic, it would have been appropriate to turn to the task of reconciliation. In 2020, Suzanne Shale identified 7 acts of acknowledgement essential to moral repair. Now, acknowledgement is a combination of deep listening, altered understanding, and mutually agreed reparative action. Instead, a societal prescriptive forgetting was encouraged by people in influential positions who had a vested interest in the construction of a post-COVID culture which reverted to the pre-pandemic status quo, a narrative which was at odds with the persistent PPE wearing and distancing that was which was still happening in health and social care communications. During the acute phase of the pandemic, health workers were objectified as heroes with unlimited coping capabilities. When health professionals engaged in a long period of industrial action, this objectification made it easier for them to be demonised by media outlets which supported the government of the time. The Royal College of Nursing first took strike action in December 2022, followed by days of action by paramedics, physiotherapists, radiographers, doctors, consultants, and others. Despite this action, concerns for the precarity of health and social care became submerged by active forgetting and a rising tide of new horrors and preoccupations, the cost of living crisis and the wars in Ukraine and the Middle East. The strikes slipped out of the news cycle, becoming normalised in the face of an unresponsive government. Next slide, please. Epistemic injustice combined with exhaustion and moral injury prompted some people to question their professional caregiving identities and practice their own self-compassionate disconnection, making substantial changes to their work-life balance as a form of self-care. Farnsworth and colleagues in 2017 considered moral pain to be a potentially beneficial phenomenon which creates an opportunity at the moment of awareness to take actions that are values consistent. Some participants who worked in health and social care used this moment of awareness to make career moves away from the roles in which their experience of PPE and distancing had caused them distress. Of the 9 participants re-interviewed in 2022, 4 had radically changed their professional role. GP Deborah had left her practice to lead a long COVID clinic and a private life coaching practice. Care home manager Alex had moved jobs twice and was in charge of a much smaller family-run care home. Natalie had moved from ITU to a bariatric outpatient clinic, and Maggie had retired from her career in children's mental health and temporarily returned part-time while completing a qualification to set up private practice, which would work around her main responsibility, which was family carer. Next slide, please. When furlough ended, Some people who had taken on unpaid caring responsibilities out of necessity couldn't recommit to their careers. They could no longer be fully available to their employer because they were still required as carers due to the continued and entrenched absence of other support. Here, carer support worker Liz describes how they were forced to accept that their caring role had become their primary identity. In October to December 2023, there were 9.28 million people aged 16 to 64 in the UK who were not in work, nor actively looking for work. That's 21.9% of the working age population. Next slide, please. Here, Maggie describes why she and many other colleagues decided to step back. Autonomy to practice self-compassionate disconnection was dependent on financial security and a moral reconciliation with detaching from care responsibilities. The former was less of a dilemma for many health and social care workers. Experienced staff were more likely to be reaching the age when they could access their pensions. While the government's refusal to address pay and conditions meant that jobs in retail and other non-care industries would pay a similar wage for less responsibility and less moral distress. Replicated nationally, this act of self-compassionate disconnection has led to health and care services being unable to return to pre-pandemic levels. Described as the Great Resignation, other essential professions also lost people with the skills, knowledge and experience. And this has consequences for the UK's emergency preparedness. Next slide, please. According to the United Nations Office for Disaster Risk Reduction, a disaster is defined as a serious disruption of the functioning of a community or a society at any scale due to hazardous events, interacting with conditions of exposure, vulnerability, and capacity. The threshold for a disaster is crossed when a society or community lacks the capacity to respond to challenging circumstances. And that is why the attrition of the professional health and care workforce is alarming, because it lowers the threshold where disaster is made manifest. Their absence contributes to high levels of long-term sickness in the general workforce due to long waiting lists. And it also reduces workforce capacity in all professions as people withdraw from the workforce to take on their family members' social care in an unpaid capacity. This makes the population less able to respond to a diverse range of natural and man-made challenges. COVID-19 interacted with the concurrent and pre-existing factors of structural violence, epistemic injustice, and betrayal of trust in the manner of a syndemic. Merrill Singer coined the term syndemic in 1996 to describe population-level clustering of social and health problems. Syndemics emerged due to a range of shifting circumstances, including a change in political and economic conditions, social behaviours, rapidly developing technology, and/or breakdown of public health protective measures. The 2023 UK National Risk Register has conducted a reasonable worst-case scenario assessment for all kinds of risks: terrorism, environmental events, cyber attacks, systems failures. The register predicts a 5 to 25% likelihood of another catastrophic pandemic in the next 5 years. In the face of the high probability of another event, which will require the use of PPE and distancing in health and care communication, I conclude that this syndemic is an unrecognised, ongoing disaster of gradual onset. Last slide, please, Jane. One day, Veronica found herself inexplicably sobbing for 20 minutes in the car on her driveway when she came home from work. She had been attempting and failing to conduct dementia assessments by video call. The word "there" in Veronica's heartfelt declaration on this slide does not describe a place or even an event. It describes the accumulation of sensations and emotions, of a myriad of disturbing encounters and forced separations, and the anger and frustration caused by repeated, shameless leader exceptionalism. In a just published critique of the standard model of moral injury, A. Camperer and colleagues note the limitations of considering moral injury as the result of a discrete, linear, individual, self-contained event implied in the term potentially morally injurious experience. Instead, they note how moral injury can arise from the accretion of seemingly ordinary events and circumstances. The stories of my participants speak to the circular, persistent, messy, insidious nature of collective trauma, the often malevolent contribution of official structures and actors to this trauma, and the toxicity inherent in the failure to acknowledge gradual disaster. Collectively, these factors are indicative of a potentially morally injurious culture. A new culture needs to be established, one which recognises the need for moral repair and for practical interventions to heal the fabric of England's health and social care landscape. If not, who will rally to the call when the next inevitable national emergency comes, whatever form it might take? Thank you.